Hey there, my name is Doug Morse, and with my wife Dina, we have a company called No Stress Training. And with No Stress Training, we produce classes to prepare you for certification in ACLS, BLS, PALS. We teach EKG recognition and 12-lead interpretation. And our contact information is in the workbook that you have that goes along with this video, and also in the comments and subtitles below. We're going to start getting you ready for ACLS by going through a series of 5 videos, each one devoted to a different protocol, starting with video number 1 and protocol number 1, and that's the protocol for bradycardia. Now, the most important thing to recognize about a bradycardic rhythm in a patient who has symptoms that are consistent with bradycardia, hypotension, and just decreased levels of metabolic performance, is that this bradycardia and the other symptoms that you're looking at are just that. They're symptoms. They're not the pathology that's creating the symptoms. Therefore, the American Heart Association requires that before we initiate treatment, before we do anything to raise this patient's heart rate, we go through a diagnostic phase. Now, that diagnostic phase should at a minimum include, of course, vital signs and taking a history and going through the patient's med list, but also get a 12-lead EKG. Get whatever labs your facility is capable of processing, and at least get a telephone consult with cardiology. Here's why this is so important. This patient with a sinus bradycardia and mild hypertension and mild symptoms related to the bradycardia, when you do a 12-lead EKG on him, comes back with ST elevations in leads 2, 3, and AVF. And if you're familiar with 12-lead interpretation, you know that that's an inferior MI. And you also know that an inferior MI has a distinct personality associated with it. You frequently find these patients pale and sweaty, sick to their stomach, hugging a trash can, barfing into the trash can because they're so nauseated. And that nausea and the paleness and the diaphoresis comes from the bradycardia and the hypotension that's associated with an inferior MI. Well, another interesting thing about an inferior MI is that it's the MI that you're most likely to survive. The survival rates from an inferior infarction are higher than other infarctions because of the bradycardia and the hypotension, which are cardioprotective because they lower the heart's workload in the midst of the evolution of this infarction, the evolution of this crisis of oxygen supply and demand. So, if you do a 12-lead on a bradycardic patient, even if they're symptomatic and hypotensive and it shows an inferior MI, you're not going to treat them under the bradycardia protocol. You don't want to raise their heart rate. As a matter of fact, you're going to flip a couple of pages over to the acute coronary syndrome protocol and you're going to treat them under that protocol instead. Labs. If you got a patient who's under some kind of chronotropic rate control medication, cardizem for example, and they've taken too much of it, they're going to be bradycardic. Using a different chemical to push their heart rate up to counteract the over-therapeutic levels of the chronotropic medications they're supposed to be taking is not going to be helpful. Instead, recognition of the non-therapeutic range of their medication and bringing that back into normal range is what's needed. Labs may also indicate through chemical studies that the patient's got a life-threatening electrolyte imbalance. Hyperkalemia, for example, can present as a bradycardia. And raising a patient's heart rate while being ignorant of life-threatening hyperkalemia can threaten the patient's life. And then finally, the consultation with this cardiologist. You hand the cardiologist your 12-lead, they look at your diagnostic package, they listen to your history and story, and this physician, she says, you know what? Just bring him to the cath lab. Forget all that, bring him to the cath lab. I'm going to put in a pacemaker, I'm going to do a diagnostic or therapeutic catheterization, and we're going to go straight for definitive treatment based on what I see here. So this diagnostic phase should precede treatment, and it's so important that they address this on many of the ACLS written exams. I want you to imagine an ACLS written exam that you're reading in your test, and they give you this rhythm, and they give you a patient who's moderately hypotensive, and they don't feel good, and they've got poor peripheral circulation, they're kind of weak and dizzy, and they say, what do you want to do for this patient in this question? And they give you choices A, B, C, D. 3 of those choices are going to be legitimate treatments that come right out of the bradycardia protocol. And they are legitimate treatments for a patient with that rhythm and those symptoms, but all three of those choices are incorrect. The answer you want is one of these diagnostic choices. Before treating, I want to do a 12 lead. Before treating, I want to get the labs that are available to me. And before treating, I want to talk to cardiology. Now, there is one notable common sense exception to that, and that's the patient who's in a bradycardia that's producing cardiac failure, the patient's vital signs are tanking, the patient's circling the drain. That's a case where, in your opinion, the patient is probably not going to survive a diagnostic phase, and you leap immediately to aggressive interventions. And we'll talk about that kind of situation in just a minute. All right, so for this patient with relatively moderate symptoms of a relatively moderate bradycardia, the treatment of choice, regardless of the rhythm on the monitor, is always going to be atropine. You're going to give an initial dose of atropine at a small 0.5 milligram bolus. Atropine is a parasympatholytic medication. It blocks the effects of the parasympathetic system. Now, the parasympathetic system is what you feel when you come back to class after a big lunch. You're drowsy and you have trouble staying awake. Blood is diverted from your brain to your guts. Your heart rate drops, your breathing drops, and you try to take a nap. By blocking the effects of the parasympathetic nervous system, you cause the heart rate to rise in a more gentle fashion than if you pushed it up through sympathetic stimulation. So this is the preferred method and the most gentle method for raising a patient's heart rate when there's some kind of cardiac dysfunction. Now, one interesting thing about atropine is that you and I and every other person out here has a different chronotropic threshold at which we respond to atropine. I may be super sensitive to atropine and my heart rate jumps up immediately with that initial bolus, but other people may require more and more atropine to get the same effect. For that reason, there is a pathway in this protocol where you continue giving atropine in these small, titrated, half milligram doses every 3 to 5 minutes until you reach the desired physiological effect, or you hit a maximum of 6 doses, which is 3 milligrams. Now, I said, or you reach desired physiological effect. What does that mean? Well, desired physiological effect is not a number on the monitor. If I am bradycardic with a heart rate in the 30s and you give me a couple of atropines, 2, 3, 4, and my heart rate comes up to 52 at one point, but with that heart rate of 52, my peripheral skin color and temperature is better. My radial pulses are stronger. My blood pressure raises to a more comfortable level. I'm not nauseated anymore. I'm not dizzy and hanging on to the bed. Leave me alone. Stop treatment, hold me right there. The atropine does not cure the patient. It does not abolish the bradycardia. All it does is it stabilizes them for a few hours until this physician can get there and establish definitive treatment. Now, another thing that is a little bit unusual about atropine is that for some patients it won't work at all. Atropine works by blocking parasympathetic receptors, and anatomically those are only present in the supraventricular heart. Therefore, rhythms that are bradycardic that originate from the supraventricular heart should be atropine responsive, and this is the desired track for treating those patients. And this is the track that you should stay on if your patient displays a sinus bradycardia, a junctional bradycardia, or a bradycardia that's associated with AV node dysfunction, an AV nodal block, like a first-degree AV block, or a second-degree AV block, Mobitz 1, also sometimes called a Winky block. So what happens if your patient doesn't present with one of those rhythms? Suppose they present with a bradycardia that has a obvious ventricular-based origin, like this third-degree heart block. Here what you have is very slow, wide complex QRSs coming from a ventricular pacemaker at a slow rate, in this case 36. When it comes past the initial diagnostic phase and it's time to treat this patient, you're still going to give them this initial atropine. Remember, atropine is the initial treatment for every symptomatic bradycardia. And when you give a patient in a third-degree heart block atropine, you're doing a diagnostic test. Here's one reason why we want to go ahead and give this patient atropine. Let's say that we think this is a third-degree heart block. We're pretty sure, we're 99% definite this is a third-degree heart block. But I go ahead and I give him the atropine, and when I do that, I see an increase in the speed of the P waves because that's a supraventricular pacemaker, but the QRSs remain at the same slow, regular, staid rate. When that happens, when the P waves speed up and the QRSs don't, I have proven AV dissociation, which is the defining characteristic of a third-degree heart block, and my confidence in my diagnosis just went up. In addition to that, they want you to give this initial atropine to these patients in these wide complex tachycardias because frequently patients will come into the emergency room with a sinus bradycardia, but another comorbidity like a left bundle branch block. So the initial evaluator sees a slow, wide complex rhythm and they jump past atropine to some of these other treatments when they should have stayed with atropine because this was indeed actually a sinus rhythm. So if I give that initial atropine to this slow QRS complex bradycardia and the QRSs speed up, I need to reevaluate my diagnosis. It's very possible what I'm looking at is actually a supraventricular rhythm. All right, assuming that we have confirmed that this is a third-degree heart block and we've given this initial atropine, at that point in time we have to recognize that atropine is not going to be a good treatment moving forward. We need to switch to something new. And that something new is one of three choices. And these three choices are not prioritized 1, 2, 3. You can choose any of these three choices for this patient based on what you have available at your facility and what you think is best for your patient. Two of these are sympathomimetic infusions. One is an epi drip, and the dose is 2 to 10 micrograms per minute. And the other sympathomimetic infusion is a dopamine drip. Dopamine is a weight-dependent medication. Its dose is a little different. It's 2 to 20 micrograms per kilogram per minute. Now, sympathetic stimulation will improve the heart rate in any rhythm, regardless of whether it comes from the supraventricular heart or from the ventricles. So you will end up with a faster third-degree heart block if you start an epi or dopamine drip on this guy in therapeutic range. However, the dark side of that is the fact that sympathetic stimulation stresses the heart. It vastly increases myocardial workload and O2 consumption. So you're stressing this heart. And this is a sick heart. Even if you don't know anything else except the cardiac rhythm about this heart, you can clearly see that this is a sick heart. So you have to weigh the benefit of raising their rate with the risk of causing further damage to potentially an unknown pathology. Because of that, if you choose one of these sympathetic stimulators as your treatment, you always start at the lowest possible dose and you titrate slowly up again to the desired physiological effect. And when you hit that desired physiological effect at the lowest possible dose, you hold there. Well, if these two treatments are so dangerous, what about the third treatment? The third treatment is the use of a transcutaneous pacemaker. TCP, or transcutaneous pacemaker, is a module that's built into your cardiac monitor in most cases. And it involves you taking the defibrillation pads, which are often combo pads that will do defibrillation, cardioversion, and pacing, and you put them in the appropriate places on your patient's chest, same place where you defibrillate, and then you come back to your pacemaker and you turn it on. When I turn the pacemaker on, it will start sending shocks through my patient's chest at whatever rate I established, in this case 60, with the intent that each one of those electrical shocks will stimulate the heart to contract and produce a pulse wave. When I go back to my EKG, I see that I'm not completely successful. Only about every third pacer spike is producing a QRS complex. This is known as incomplete capture. Incomplete capture occurs because these machines initially default to a very low energy level, 5 milliamps in this case. It is now my job to raise the energy until I find the lowest energy that provides effective capture after every pacer spike. If your patient is circling the drain, that patient I was telling you about earlier who's in cardiac failure and you have to intervene immediately, even before you do diagnostics, most of the time you're going to go straight to TCP, you're going to slap it on them and you're going to crank up the juice and you're going to get capture. And then you'll slowly bring the juice down to the lowest effective energy level that produces capture. But if you're doing this in the course of a patient who's conscious, a patient who is doing a little bit better metabolically, and you've given the initial atropine, it's kinder to start at the low energy and then work slowly up until you find the energy that produces capture. Now I know with my particular simulator here that I'm going to get capture when I move up to 40 milliamps. So I progress pretty quickly through 5, 10, 20, 30, and then finally to 40 milliamps. At 40 milliamps, I can see complete capture because I see a QRS complex after every single pacer spike. That's electrical capture. Now to verify mechanical capture, I need to go back to my patient and I need to check pulses to make sure the patient's pulse matches this 60. Don't, however, go to the carotid pulse. This pad, which is producing myocardial contractions, is also producing these violent skeletal muscle contractions as well at exactly that rate. So it's very easy to be fooled by muscular tremors, muscular spasms that exactly match that rate that you're trying to feel. So you're probably going to use a radial or femoral pulse, some pulse site that's further away from those pads. Now, what's the drawback to using TCP? If these two are effective but dangerous, why don't we just always go to TCP? One of the reasons why we don't always go to TCP is because it's just miserable for the patient. Plus, you may not have this device available to you. I have had a patient, my very first patient, that I had to pace out of a 3rd-degree heart block. The guy had a very slow heart rate in the 20s. He was unconscious, responded only to a painful sternal rub. We put the pacer on him. We paced him. I got mechanical capture. I got pulses back. I was so happy. But as his perfusion status improved, as his cerebral perfusion improved, as he woke up, his eyes open, and he's sitting there jerking spasmodically from this pacer, and he turns to me and he goes, "Turn that shit off." That's a direct quote from this guy, and we had to sedate him. So the point of that story is to be prepared to sedate a patient as their level of consciousness improves. At the best possible circumstances, this is a short-lived bridge device to get the patient from your emergency room to your cath lab where they'll put in a permanent transvenous pacemaker. If your patient has to stay on a pacemaker for any period of time, be prepared to continuously monitor that patient for loss of capture as the heart fatigues at the original energy level. And you constantly have to keep kicking the energy up to keep maintaining capture, which means that you have to keep increasing the sedation so the patient can tolerate it. So it's a miserable experience. So to recap, a patient with a symptomatic bradycardia should first be approached with diagnostics. Your greatest hope is that you're going to find something definitive that you can treat and you don't have to go to this protocol at all. But if you don't find something definitive that leads you in any direction outside the protocol, you're initially going to treat everybody with atropine. And then if they're in a supraventricular-based rhythm, you're going to stay with atropine until you get their heart rate where you want it. If they do not have a supraventricular rhythm, you're going to move to one of these ventricular effective treatments of either an epi or a dopamine sympathomimetic infusion or TCP, and you're going to wait for that consultation from this cardiologist. A short list of the rhythms that might require you to resort to these 3 treatments include 2nd-degree AV block type 2, 3rd-degree AV block, and idioventricular escape rhythms. And that concludes our discussion of bradycardic rhythms. If you have any questions about any of these protocols as we're going through these videos, send me an email, jot down some notes because we're going to get together soon and we're going to do some practical exercises where we put these into patient scenarios and work them through, and we'll be happy to answer your questions then. Until then, thanks, and we'll see you soon.